Good afternoon, everybody. I'm going to get us going. Thank you, everybody, for joining us. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. And before we begin, a word of thanks to everybody who made today happen, in particular to Meredith Brown and Alicia Noel. Thank you. This is the second event in our new series on the coronavirus. As everybody knows, this pandemic has rightly captured attention around the globe. But for all our thinking about the coronavirus, it can be hard to find space to pause and view this challenge in a larger context. These events are meant to be such spaces where we can look at the coronavirus through the lens of contemporary public health issues. Today, we're going to explore an issue that I think is critical, which is the intersection of mental health and coronavirus. We know from other large-scale traumatic events that trauma can shape health in the near and long term. We can expect the same in the context of this pandemic. Our speakers will help us better understand what we know, what we do not know, and how we can mitigate these consequences in the case of COVID-19. We are truly honored to have an outstanding panel with us today. Each panelist will speak for about 10 to 12 minutes, and then I shall moderate questions from the audience. Feel free to use the question tab in your Zoom browser, and I will do my best with help from Meredith to get to as many questions as we can. So I'll move on to our speakers. Our first speaker is Professor Kerstin Koenen, Professor of Psychiatric Epidemiology at the Harvard T.H. Chan School of Public Health, and really a leader in thinking about these issues over a very long time. I look forward to hearing from her. Professor Koenen.
Thank you, Sandro. Let me just share my slides and on here. Let's go back. Okay. Great, thank you. Hold on, I'm at the end here. Hold on. I'm still learning this Zoom thing, this Zoom webinar thing. So now everyone's on. Okay, here we go. Thank you, Sandra. I'm happy to be here today, and I'm delighted to be able to talk about a topic that's really close to my heart, and that's population mental health in the context of this pandemic. So one of the things we know is that the COVID-19 pandemic is an extreme stressor. I think we all can acknowledge how stressed we feel. But that from what the research we have, it has multiple characteristics that we know are toxic to mental health. And we see these images on our screens every day of New York City, empty, places in lockdown, coffins in Italy. And the pictures on the right are ones I took. One is at my local supermarket when I went grocery shopping recently, and the other is the park across my house, which is now closed. And some of the characteristics that we see with COVID-19 that we know are problematic for mental health are it's novel. None of us have ever experienced anything like this before. I was in New York with the 9/11 terrorist attacks, so I've had that experience personally, and I would say this feels very different from that or any other disaster that I'm aware of in the United States anyway. It's threatening, it threatens our health, our jobs are threatened, there are shortages, it's unpredictable. It seems like the news is changing every day, even from our own institutions. I'm at Harvard, and we were told something in the morning and then something would be changed in the afternoon because all of our institutions are trying to catch up with how to deal with this. I know myself, I feel this lack of control. So all of these are things we know are characteristics of stress that we know are problematic for mental health. On top of that, we have extra stressors, which are social isolation. So now we're all being told to stay at home, depending on where you are in the country, but certainly in Boston, in New York, California, we are supposed to stay at home and only interact with whoever lives in our home with us. So even not seeing family members who are, if they don't live with us in our home. We heard about stigma, particularly for Asian Americans feeling stigmatized, and we can anticipate people are already experiencing bereavement, and we can anticipate more of that. And these are all things we know are toxic to mental health. We also know from other pandemics that there's adverse mental health effects. So it's not just that we're anticipating this based on our own experience now, but we know this from the research. So I'm just going to give a few examples, but there's a big literature on this. For example, there was higher rates of suicide among older adults in Hong Kong during the SARS pandemic, linked to isolation, not just disease, but isolation due to the disease. There were long-term follow-ups of SARS survivors, found that they had high rates of mental health problems and chronic fatigue syndrome, even though they recovered from SARS itself. And when in people who experienced the Ebola pandemic in Sierra Leone, a year later, they found high prevalences of depression and PTSD symptoms, with the majority of people having some symptoms of anxiety or depression, even 1 year after. And we also have emerging evidence from China that suggests there'll be wide-ranging adverse effects on mental health. So some of these papers just came out this week that elevated mental health problems among healthcare workers who are exposed to COVID-19. And this article says that they may need psychological support or intervention. So we can anticipate the stress of dealing with COVID-19 might be negatively affecting the mental health of our health providers. They found mental health problems associated in well people, but associated with social media exposure during the COVID-19 outbreak in China. And they found a prevalence of depression and anxiety of about 50% in the Chinese population. And then most recently, there was an article talking about there's a public mental health crisis following the COVID-19 pandemic in China. So that's pretty doom and gloom. And so I wanted to end this part of my talk with a little bit about what can be done, which I think my presenters, especially Patricia, will talk about more. So I'd like to argue, based on what we know we're experiencing now, what we know from prior pandemics, and also from the evidence coming out of China, that we need a concerted public health effort to address mental health in the COVID-19 pandemic. That we know it's going to be a problem, and that's something we need to address proactively. So, for example, for the sort of infectious disease aspect of the pandemic, we have, this is from Google, do the 5, wash your hands, cough into your elbow, don't touch your face, keep safe distance, and stay home if you can. Now, this is really replaced, again, for many of us who are just being asked to stay home as much as possible. And I've been wondering if we need a similar 5 for mental health. Now, coming up with something like do the 5 isn't my strength. I suspect Dean Galea could come up with something much better than me here, or my panelists could come up with something, or somebody in the audience. But these are just some things I've been thinking about, and I would love it if someone could come up with something that was catchy on mental health. So one is we need to recognize that mental health is going to be affected by this. And rightly so, there's all the focus is really on the infectious disease part of the pandemic, and that totally makes sense. But we need to recognize that mental health is going to be a problem, because the first step in solving a problem is we have to recognize that it exists. The second thing is we need to broaden the social safety net. And we can, one of the arguments for doing that, it's really been focused around the economy, which again is very important. But by buffering people from the economic consequences and the other social consequences of the pandemic, we are also protecting people's mental health. So there's efforts around this, around keeping daycare facilities open so people have a place to send their kids if they're essential workers, halting evictions, a stimulus package. But we can see these big public efforts in terms of our government as ways of buffering adverse mental health effects of the pandemic. The third thing we need to do is to identify and support those most at risk. And I think that Sarah will talk some about risk factors, but these are just some of the groups. I'm sure I've left some out. So people with prior mental health problems or current mental health problems are more at risk of having those get worse during the pandemic. People suffering from addiction. There's been articles about people who are in recovery from addiction and can't go to their, usually AA groups, et cetera. They're also at risk with the increased stress. Something I've heard recently from colleagues of mine who work with families is families who have high conflict or who've been in treatment because of histories of domestic violence are finding increases in conflict, child abuse, and domestic violence in the families. You can imagine this is a stressor, and suddenly this family, which was having a lot of issues, is now thrown together. The kids don't have school to go to, maybe the parents don't have work to go to. And my understanding is DSS is not doing anything, can't really do anything right now about this. So that's a problem. Families with special needs kids. My son has dyslexia and he's a strong student, so it's less of an issue for him, but I'm on a lot of email lists about people with kids with special needs at home who, even if the school's doing something, it doesn't meet the needs of special needs kids, people who are already socially isolated, and healthcare workers. So there's a lot of at-risk populations, which again argues for a more population mental health approach to the problem, because so many people are vulnerable. So one of the things I think I want to applaud, this is something from my neighborhood, but people are finding ways to help, and people on this call can think about ways they could help these different high-risk groups. So this is something from my neighborhood. On my neighborhood email list, a woman's put together money to buy masks for local hospitals, and she's changed her 501c3, who that focuses on getting money for kids' coats in the winter and is already funded for that as a way of fundraising. And these are pictures of her bringing masks and gloves to the Brigham, which is on the BI, which are near where I live. Another thing we need to do is enhance resilience. And again, Patricia will talk more about this, but there's many resources online. So for example, we've been having these mental health forums, and in these forums, we are really focused on bringing evidence-based skills, managing stress, and enhancing resilience to everyone. So we're having one next week, and people are welcome to email us and get more information if they want something that's pretty skills focused in terms of managing stress. And there's a lot of other things online. For example, ISTSS has released a lot of information on resilience and free resources. And the last thing I just want to say is, I would say one thing we can all do to help our own mental health and others is to be kind to ourselves and to each other, to our families, to our neighbors, because we are under so much stress that one of the symptoms of that is we're more irritable and impatient with each other. So I've been trying to practice this. And this is something that one of my postdocs made, which is a saying a lot of yogis say to each other. I think it goes back to Aristotle, but it's be kind, for everyone you meet is fighting a hard battle. And I think that really speaks to where we all are right now. So I'll close with this quote from Franklin Roosevelt, which I've been thinking a lot about lately because of the fear we've all been feeling. And that is his famous inaugural address, where he talked about the only thing we have to fear is fear itself. But when I went back and read it, what I was really struck with is the end of that, the second sentence there, when he says, "In every dark hour of our national life, a leadership of frankness and vigor has met with that understanding and support of the people themselves, which is essential to victory." And I think that last piece in terms of public health, the support of the people themselves, which is all of us, everyone on this call, is really essential to victory over the virus and over all the other consequences. Thank you.
Thank you very much, Kirsten. That was great. Before I turn to Sarah Lowe, who's our next speaker, just a couple of points. Number one, if I can ask anybody in the audience who has questions to use the Q&A function of the chat function. It's just easier for the panelists to see the questions, and I will do my best to get to as many of them as we can. Number one. Number two, we have maxed out the audience capacity on the Zoom, which is more than 1,000 people. And we are trying to create a Facebook overflow, but if anybody's reaching out to you and they're trying to get in, that's why they can't get in. With respect to this program, it shall be archived on the School of Public Health website, so anybody who cannot get in can see it afterwards. Very good. We'll move on from Professor Cohen to Professor Sarah Lowe. Professor Lowe is an assistant professor of social behavioral sciences at the Yale School of Public Health. Sarah.
Great. Okay. So I'm going to be talking today broadly about research findings about mental health in the aftermath of mass trauma. So I'm going to start off just addressing the issue of what is mass trauma and how is it different from other forms of trauma. So mass trauma are events that affect not just individuals, but entire communities. These include natural disasters like earthquakes and hurricanes, technological disasters, such as the Deepwater Horizon oil spill, terrorist attacks. I think we can all agree that the COVID-19 pandemic would fall into this category as well. So something I want to note is that there is an abundance of research on mental health after disasters. There is some research on prior epidemics and some emerging research on COVID-19, but we know a bit less about the effects of these types of events. And I think this is an important thing to note because of some unique characteristics of COVID-19 as compared to other mass trauma. First, its geographic scope is certainly much wider than we've seen in prior events. And secondly, its duration. So while natural disasters, attacks are the main exposure, is done within a week's time, what we're seeing here is a lot longer. So we're getting a greater dose of the trauma, but on the other hand, I think that this opens up the possibility for intervention and mitigation in a way that maybe isn't present in these other forms of mass trauma. So in terms of mental health outcomes, and in the rest of the presentation, I use the word disaster to cover mass trauma, just as a heads up. What research has shown is that disasters are associated with trauma-related disorders. So these are disorders for which an exposure to a traumatic event is a prerequisite, including acute stress disorder or reactions within the first month, and PTSD, but also other psychiatric conditions for which trauma is not a prerequisite. So conditions like major depressive disorder, generalized anxiety disorder, and substance use disorder, as well as elevated rates of other clinically relevant phenomena that don't necessarily map neatly onto psychiatric diagnoses, such as generalized psychological distress, internalizing or mood anxiety disorder, mood anxiety symptoms, and externalizing or conduct behavioral symptoms in children, suicidality, as well as negative health behaviors such as binge eating, substance use that doesn't meet criteria for substance use disorder, sedentary behaviors, so on and so forth. We also know that, unfortunately, the mental health effects of mass trauma for some people persist and are chronic. So this graph here is from a study that I've been a part of that has included low-income mothers from prior to Hurricane Katrina to 1, 5, and 12 years thereafter. And the punchline here is that even 12 years after the hurricane, rates of serious mental illness and psychological distress remain elevated as compared to prior to the disaster. And 1 in 6 of our participants still had symptoms consistent with PTSD. So this is to say, you know, certainly there are mental health conditions that persist over time, but not everyone is going to be affected in the same way. And so what a lot of the research has done has looked at factors that shape vulnerability and resilience. And so my colleagues and I have done this using what's called a pre, peri, post-disaster framework. So looking at different risk factors over time and the relationships among them, starting with the pre-disaster period. So characteristics that were evident even prior to a disaster can shape both disaster exposure, the recovery environment, and of course, post-disaster mental health. So most of the research has focused on individual level risk and protective factors, including pre-existing mental and physical health conditions, low social support, low socioeconomic status, female gender, and I included age in parentheses here. The findings with regard to natural disasters and age have been mixed, but certainly in the case of COVID-19, we're seeing greater morbidity and mortality among older people. And I think it's also notable that among children, the impact of physical distancing is probably going to vary in terms of the impact on mental health. So being separated from peers and teachers is going to have a different effect for older kids versus toddlers. And then certainly some of these other individual level characteristics apply here. For example, low socioeconomic status shapes things like whether people are able to work from home, whether they have access to testing and healthcare, the type of physical spaces they're in when they're doing their physical distancing, as well as access to internet, technology, and other enrichment materials for people who are homeschooling. As I said, there is less research on community level factors that shape mental health, but there's growing evidence that the economic and social resources within a community shape population mental health after these types of events. So now turning to the peri-disaster period, these are factors that pertain to the time when a disaster is occurring. They are affected by pre-disaster factors, they shape the recovery environment, and they shape mental health. So some of the key individual level factors here are perceived or actual life threats, lack of vital resources like food, water, shelter, medication, and medical care. So certainly we're seeing a lot of that with COVID-19. Social network disruption. So in disasters, we talk a lot about separations, and uncertainty over the whereabouts of loved ones. And here it's really the isolation that comes along with physical distancing. Losses and financial losses for COVID-19 are going to be great and on a major scale. Emotional reactions. So research has shown that people who have very intense fear, worry, anger, grief during mass trauma tend to fare worse. But on the other hand, these are all normal reactions to an abnormal situation. And the strategies that we use to cope really shape responses. So whether a person uses more adaptive strategies like mindfulness and acceptance, cognitive reappraisal, social support seeking, exercise, or less adaptive strategies such as rumination, co-rumination, binge eating, substance use. And then we also know that a greater dose of exposure via the media, such as consuming more news and social media, is associated with worse responses. And that's something that we can directly intervene upon in the current crisis. And then, of course, these disasters differentially affect communities, and factors such as the number of people affected, the extent of losses across a community are going to put people at greater risk, whereas community organizing and mitigation strategies can perhaps be protective. And then lastly, in the post-disaster period, here I have a double-headed arrow, because certainly what happens in the post-disaster environment influences mental health, but mental health in turn can influence recovery and sort of make it more difficult to recover in various aspects of people's lives. Some factors here are, ongoing effects. So injuries, losses, financial strain, continued disruptions in work. So prolonged unemployment, looking for work, making up for lost time in school. Relationship stress. So mass traumatic events are stressful, as Kirsten said, and they in turn can lead to stress in intimate partner relationships. And there is indeed research showing that disasters are associated with increased rates of child abuse, intimate partner violence, and divorce. And then certainly mass trauma have a way of bringing people together, but over time there can be a bit of weariness and fatigue and social deterioration, and this can increase mental health risk over time. And then at the community level, the resources and barriers we have for rebuilding and recovery, both within and external to communities, are going to be vital in restoring stability and mental health over time. So this is our model, and I framed it in terms of understanding vulnerability, but I think it can be also used to promote resilience. And before I start applying the model, I first want to say a couple key things about resilience. First is that most people will be psychologically resilient. So this is a graph from George Bonanno's work showing the varying patterns of responses in psychological functioning to PTEs, or potentially traumatic events. And most people are going to fall on that resilience trajectory, which is a trajectory of few symptoms and good functioning over time. So that's sort of a silver lining here. Second thing I want to say is that most trauma survivors report at least some degree of what's called post-traumatic growth. So these are positive psychological changes that occur after trauma exposure, including perceived stronger relationships with others, a greater appreciation of one's life and gratitude, a sense that new things are possible, that people are stronger than they thought they were, and a stronger sense of faith and stronger relationships with one's God or higher power. But I think also the model that I presented speaks to other ways ways of promoting resilience. And I think Kirsten's presentation touched upon some of these as well. So knowing who's at risk based on pre-existing conditions and characteristics can inform outreach efforts during this time. I think we can build psychosocial resources, including adaptive coping and strong social support networks. We can reduce exposure through our physical and social distancing that we're doing now, but also by helping people manage their media use. In the aftermath of COVID-19, resources to foster stability, knowing that it's going to take time, that people don't just recover from these types of events right away, that take months and years. And then in terms of mental health symptoms, screening for symptoms and treating in intelligent ways, such as through step care approaches, wherein people are assigned to treatments based on their initial level of symptom severity. So the people with the most severe symptoms are getting specialized care. And that's all I have. So this is my email, and I'd be happy to answer any questions in the Q&A or offline as well. Thank you.
Thank you very much, Sarah. Next up is Professor Patricia Watson from Dartmouth and from the National Center for PTSD. Just a note for the audience, several of you have asked for links through the Q&A. We're just catching up, and we'll send those links through the Q&A. And also for people who have been asking, the Facebook Live version of this has been opened. The third thing is that for those who are asking where this is being archived, it'll be archived on the Boston University School of Public Health website. Thank you, everybody. Professor Watson.
Thank you very much, Sandra. It's really a pleasure to be a part of this team. And my task is to, in 10 minutes, to talk about mental health approaches to mitigate some of the mental health consequences that you have heard about from our other excellent speakers. And I am realizing that my slides aren't advancing with my own slide on my computer, so I'm not quite sure what to do about that at this point.
Oh.
If you can just say next slide, Patricia will advance them for you.
Okay, wonderful. All right, so as you heard from the first two presenters, there are a number of issues, and when you take a look at the literature and the research on post-disaster interventions, what you typically find is that the vast majority of disaster research is related to the effects of disasters, risk factors, protective factors, and how disasters affect people. You tend to find a much smaller percentage of studies that really look at interventions or things that could be helpful for people. And we're in a particular difficult situation because of the unprecedented nature of the event that we're in right now. So in most disasters, as you've heard from the other speakers, the majority of people do recover within a year. Resilience is the norm. That varies with the severity of the disaster, but in general, what you find is 10 to 30% of people are going to have continued problems, and 70 to 90% will need something more than that. They will not just recover on their own. They tend to have a drop-off effect over time. The majority of published disaster interventions are post-disaster, and so we've been scrambling when we've been looking at the literature to try to understand the ongoing threat nature of this situation. It's much less research, and we're still kind of sorting through what's been done and what's currently being done in terms of intervention research. But as I said, it's unprecedented, and it's also difficult because in general what you see, as Sarah mentioned, there's a stepped care approach that's usually implemented after a disaster, and we are not sure what the phases are at this point. It's hard to estimate the time phases in this current event. Typically what you see is a kind of a psychological first aid early on, and then you move to interventions that are skill building, and then you move to more clinical interventions, but the phases are not easy to predict at this point. We're also running into anxieties that people have about safety and safety measures. And because of that, what's typically done in disaster situations is an outreach effort. We find that people aren't going to identify themselves as in need of mental health support. And so what usually happens is people in communities will go out and do outreach at different places, knock on people's doors, go to community events. And because that's not happening, people are scrambling a little bit to try to understand how to support their communities in this type of environment. Community capacity is almost always stretched in every kind of disaster. And because of the nature of this disaster touching almost everyone, it makes it even more difficult to have good, strong community capacity because it is affecting almost everyone. And so it can raise a number of challenges. Next slide, please.
Patricia, two things. Number one is I'm told that you can advance your slide by clicking on it yourself.
Okay, great. I just did. So
and the second thing is we just had a couple of comments from the audience. If you can lean forward because your voice is very soft, people can hear, that would be great.
Sorry, everyone.
Thank you, Patricia. Sorry about that.
That will help.
Back to you. Thank you.
Thank you. All right, so in the context of disasters, there's a model called Kinevin, which is actually an engineering model. It's a flow dynamics model that I like to refer to because in this model, the premise is that disasters in particular can be both a learning and a leadership challenge in organizations, in communities, and families. And it requires, because of the nature of this particular disaster, requires us to make sense of and respond to a number of ever-changing contexts. Things are rapidly changing from day to day. And because of that, it's going to call for people to adaptively navigate. In order to do that, they need to get information relatively quickly, and they need to respond to that information in a very quick way. And what we found from looking at the resilience literature is that people who can respond and adapt quickly tend to be more resilient. But it makes it challenging for people who, A, don't have enough time to get information that is changing every day, or are people who can't process and take in and adapt to adjust to that information quickly. And so it's going to build capacity for people, whoever is involved in response, to stay present, to stay centered and grounded, because the situation is fluid and it's changing regularly. What you'll see in organizations oftentimes is that a typical organizational model in normal times is that they look for best practices and they try to make everything consistent and predictable and based on an evidence base. But what happens in the chaos of disaster settings is that oftentimes you have to come in, establish control early on, and then look at the situation as being in flux. When situations are in flux, it requires a lot more communication, a lot more feedback for leaders, a lot more interactions between staff and leaders in organizations, between family members in situations like this. And as Kirsten said, a lot of kindness and understanding. People need to be patient and be able to check in with each other and set rapid ground rules and boundaries. That none of us are going to be at our best, so we need to talk more and we need to make decisions. Sometimes we're going to fail and we need to be patient with that and keep trying and move on. So we have to have a willingness to experiment often, to remain creative in our vulnerability, and to keep trying new tasks and new strategies. What we know from looking at the literature is that there are a number of protective factors that have been identified as well as risk factors. Sarah touched on these. Oftentimes we will look at the risk factor literature and the protective factor literature to design and adjust interventions based on the context. We can't necessarily adjust the risk factors and protective factors that are demographic or biological or personality, but we can look at the protective factors that are related to resources and people's ability to adapt. So we know, as Sarah and Kirsten alluded to, that the more resources a community has, the more resources a person has, both socially and emotionally, the more resilient they are. We also know that when people can seek support from others, they tend to be better able to recover and adapt. And that's a skill set that not everyone has. Some of the people on this call have amazing social skills, but typically what we find that for people that are high functioning is that their social skills are more geared towards helping others, and asking for help is often a skill set that they're not used to. So that can be tricky for people that are highly functioning in most settings. The ability to reframe, to take things and look at them in a more optimistic way or in a more hopeful way, or to focus on things that you can control is also a protective factor. And fitting coping strategies to the context we're finding is more protective for people. For instance, in studies with first responders, they found that in the middle of intense stress, distraction is a chosen coping strategy, and that coping strategy is usually focused on just attending to what needs to get done, not attending to what's going on inside yourself. They have found that when first responders do that, their distress levels are actually lower, but they also need to adapt later on and start to integrate and evaluate and reframe and do all the other types of strategies that are necessary in order to reduce PTSD in the long run. So looking at the coping strategy literature is very interesting for me because we're finding there's no one size fits all. Also, people's ability to make meaning of their situation based on their own personal values and the hardiness factors of doing the things that one can control and believing that you can have some control over events, to believe that change is normative as opposed to stability, so you're able to adjust quickly, and to use positive religious strategies or spiritual strategies tends to be adaptive and also lead to resilience. So we've taken the literature and mapped it onto these 5 key elements that seem to be better related to people's ability to adapt, especially in ongoing threat situations. And I won't read every single example here, but we know that when people are able to get to a place of greater sense of safety, if they're able to find ways to calm down, if they're able to remain connected to positive social support and reduce negative social support, which are things like people saying, why haven't you gotten over this yet? That type of thing. And if they can have a greater sense of self-efficacy, which is being able to feel like you can get through a situation no matter what's going on. And lastly, if they have a greater sense of hope. Hope is mapped onto optimism. It's mapped onto having more resources. It's mapped onto feeling like things are going to be better in the long run or at some point. It's mapped onto spiritual and values-based types of things. So if you remember nothing else besides this slide in terms of intervention, we found that when people can have one or more of these elements in their life, both in an individual sense and in a public health sense, they tend to do better in situations of ongoing threat. So we've tried to create at the National Center a number of fact sheets that are organized around these elements related to managing stress, specifically trying to focus on supporting healthcare workers and first responders, community leaders. We had a webinar last week that you can access through the consultation program at the National Center that was related to how mental health providers can adjust their evidence-based treatment based on the current situation. And we're working on handouts now about grief and supporting employees as a leader. And we also have tried to apply a stress first aid model, which also maps onto these 5 elements. And we've had webinars for healthcare workers and first responders as well, because we found that this model, which is focused on peer support and self-care, is important at a time like this because people aren't always going to be able to access mental health or have the time to access mental health or be able to meet face-to-face with the mental health provider. So training people to be more supportive of each other in their work environments can be a measure that carries them through for a period of time until they can get more intensive help that they need, if they need it. And lastly, we have models that are more flexible, models that are based on evidence-based treatments, cognitive behavioral treatments. Those for psychological recovery is one that we developed. There's the World Health Organization has Problem Management Plus. We developed this model with Richard Bryant and others to help people speed up recovery and to enhance their abilities. And it includes a lot of the typical mental health approaches in cognitive behavioral treatments. But the model itself is much more flexible. You pick and choose, like a recipe book, what the person might need in terms of adapting their existing skill sets or developing new skill sets to get through what they need to get through. Lastly, I just want to point out that there are few cognitive behavioral treatments that have been designed for ongoing threat. Richard Bryant and his shop developed one that was based on ongoing terrorism threat, but I think it has a lot to say about the existing situation in the sense that they were trying to teach people how to deal with anticipatory anxiety, and they taught them how to understand their reactions, to practice calming strategies, to really take a look at their thoughts and identify what might be unrealistic, to modify it in the context of looking at absolute risk and what needs to really be protected and what they can play with a little bit in terms of continuing to function in their lives. So it might be a nice study for people to take a look at if they're looking to adapt existing cognitive behavioral treatments. They found good results with the approach. So I just want to take home messages are to try to be as flexible. We have to be flexible now, to be as practical as possible, adapt to the context and the phase, which is really challenging at this point, to try to be evidence informed as much as you can. And we're looking at providing a spectrum of services, both peer support and more formal interventions because of the context. To be creative about how you implement strategies. Many have to be telehealth now. and to contribute to the evidence base, because right now we need more evidence in contexts like this. Thanks very much.
Thank you, Patricia. Thank you, Professor Watson. So I'm now going to ask questions of the panelists from the audience. We have a lot of questions, so I'm going to try to go through them fairly quickly. I'll start with one for Professor Cohen and Kirsten. The question is, I'm a case manager from a nonprofit helping survivors of violence. I'm wondering what we could do to support our clients better at this difficult time.
Thank you for that question. So I think that a lot of the strategies that Patricia mentioned in terms of, I actually liked her 5 very much there, would be useful for your clients. I think that one of the big challenges right now is safety and making sure clients stay safe. So one of the things we've been thinking about is kind of going in risk identification mode. So if your clients are in situations where there's previously been violence or where there's risks, is helping them be aware of the increased risk and really work to de-escalate situations. And then the other piece would be to use some of the kind of coping strategies and stress management to manage their own stress and reactivity during this time. And if you email me, I'm happy to send, we actually have like a lot of specific tips on that. I'm happy to send it to you. So if you can send me an email, I can send you that sheet we have.
Thank you. Thank you, Kirsten. A question, maybe Sarah, I can direct this to you. Can you talk a little bit about why the majority of people who do recover are resilient? What are the fundamental conditions that make people resilient during these events?
Yeah, that is a good question too. Thank you. So I think the most robust predictors of resilience are lower exposure. So that's one thing. So, whereas bereavement and having an inordinate number of stressors during a mass trauma are inversely associated with resilience. Being healthy prior to the onset of a mass trauma in terms of one's mental health, and then strong social support networks. So yeah, I think those are probably the 3 biggest ones.
Let me just add a small editorial comment from a lot of work that we've done. I agree completely with Professor Lowe. Social support always emerges as one of the strongest protective factors here, which of course makes it particularly difficult in a time of physical distancing. And I think separating physical distancing from social distancing at the moment is critical. Dr. Cohen recently wrote a piece about this for people who could see it in Thrive Global about trying to maintain social proximity, social support in a time of physical distancing. There's a question, maybe Patricia, I can direct it to you. Can you comment a little bit about children, resources for addressing these issues in children and additional factors to consider in younger populations? Patricia?
I'm sorry, you froze a little bit, so I didn't know it was for me. So I would say that the Child Traumatic Stress Network has some great materials for talking with children. And I would say that in particular, tailoring your conversations with them to map onto their appropriate developmental level is pretty critical. I would refer you to the psychological first aid materials that both Child Traumatic Stress Network and the National Center for PTSD have on our website, because at the back of the psychological first aid manual is a number of excellent tables about how to talk with children at different age levels and what key points you would want to get across and how you could get those across to them. So I think that might be a good resource for you right now.
Thank you, Patricia. Let me direct one more.
I was going to make a plug for Kirsten's team that Archana Basu put together a great handout on talking to kids of different developmental levels about COVID-19.
Great.
Very helpful people.
Wonderful.
Patricia, one more question for you. As the pandemic goes on, there will definitely be an increase in demand for mental health services. I agree. How are mental health providers bracing for this increase in demands, and what are some ways that mental health care can adapt in the wake of this pandemic?
So what I have seen in our network in particular is that mental health providers are really reaching out to each other to try to talk with each other about how to support each other at this time. It can be very challenging. So again, that social support element needs to happen with providers as well. And I think different systems have different ways to do that. But I would encourage everybody to reach out and start to have case consultation and discussions about how do we adapt, how do we do this type of thing. As I said, our consultation program at the National Center for PTSD had this webinar that talked about how to adapt materials, how to adapt treatments for the COVID situation, and it's recorded on the website, so you can take a look at that. We're also in the middle of creating a fact sheet for providers about how to adapt mental health treatments, and we have a whole table at the end of it about kind of taken from our SPR manual of looking at particular thoughts that people could have and how to move them in the direction of being more helpful thoughts, so that it's very specific. So hopefully that will be posted and can be a resource for you as well in the next week.
Thank you. Kirsten, maybe we can direct this one to you. I can't decide if to be hopeful or not about this question, but the question is, given the decline in the economy and the lack of priority given to mental health in the US, do you think mental health will be more supported after COVID-19? This event will cause a decline in mental health for many, and I'm wondering if this event will finally open our eyes to the importance of mental health.
Well, I hope so. That would be one good thing that could come out of this. I think that the reason I would feel hopeful about this is because of what I've seen happen in China. So I'm in touch with a number of mental health professionals in China, and they have seen an increase at the government level, a recognition of actually following SARS epidemic and then through now, a recognition of mental health, which was at least somewhat attended to in the pandemic. So that actually, they saw a bit of a shift there. And so that makes me hopeful that people will be responsive here. The other thing that I've seen is that I think the interest in this webinar shows that people are interested in this topic and talking about it, and that we're actually getting a lot of information disseminated out there. And this shift to telehealth, I think, is not something we're going to be able to retreat from. I think now that once we get these things out there, they will be out there, and that will continue. So that makes me hopeful. So let's choose the side of hope.
Kirsten, I also like to choose the side of hope. It's better than the alternative. Let me ask you one more question for you. Do you have any particular advice? There's a cluster of questions about groups who are at high risk, have previous trauma. So it's a combination of either war or genocide survivors, but also people who are on the front lines today dealing with really hard conditions, particularly in the absence of PPE. So do you have any particular advice for those high-risk groups today?
So I've been thinking about this a lot. The first piece of advice I have is that all of these groups have survived terrible things before, and thus you will be able to get through this. I think one of the things you can think about is what has worked for you in the past. So yes, you're triggered now, but you all have, in some ways, maybe you may be more vulnerable, but you also may be more resilient because you've had to overcome trauma already. So I would pull on, my first piece of advice would be to pull on resources that you've used in the past, and recognize that you need to actively use them now. And you're gonna need to find more creative ways to do that, probably given the social distancing, some of our resources we can't use. So, and that's another thing we've been trying to address in some of our handouts, and also all the resources that Patricia pointed to. The National Center for PTSD website has a lot of very specifics on that, because dealing with veterans, they commonly deal with re-traumatized populations.
Thank you. Sarah, let me direct this to you. Can you talk a little bit about how leaders can model effective communication in this time, and what can leaders say at all levels? I'm paraphrasing a number of questions to alleviate anxiety, confusion, and perhaps help mental health. What should leaders be saying?
That is a really good question. I mean, I think as a leader, the first thing that would be helpful is validating people's emotions, and sort of giving voice to them that, yeah, people are feeling worried and afraid and sad. And, that is normal and we should expect that. But at the same time, instilling hope for the future and a sense of collective efficacy, that we as a community are strong and that we will get through this and support each other. So doing those things sort of in parallel, I think is really important, and not, telling people that they shouldn't be afraid or that this isn't something to be scared of, because, you know, it is scary and people are rightly worried. But at the same time, I do think it's true that, you know, over time, we will be resilient.
Thank you, Sarah. Patricia, maybe I can direct this one to you. I'm a psychologist and I work in a hospital. I'm trying to help health professionals like nurses and doctors to keep working and try to maintain positive mental health. Do you have a couple of good tips for me to work with these professionals?
So as I said earlier, the issue of communication is particularly important. And if you think about those 5 elements, as Sarah and Kirsten have both pointed out, if you could be somebody in an organization who talks with people and asks them, how are you doing about safety? What do we think we need? Let me tell you what I think we can do, but I need to know specifics about what you think you need. I would say the top recommendation that I would give is that leaders and psychologists in organizations like this are reminding people regularly to be patient and kind with themselves, as Kirsten had said, because we're having to make decisions, especially in healthcare organizations right now, which have a high risk for what we would call inner conflict or moral dilemma, sometimes called moral injury in the literature. But there will be decisions that may need to be made that people are going to be potentially very hard on themselves about. And so people need to be continuing to talk about this in organizations so that a person doesn't go down that track of blaming themselves or getting overly angry at themselves or conditions or leadership. So communication is really key, helping people to talk through what their needs are, to do your best to be flexible and show support, as Sarah said, just asking questions, keeping people informed, being patient, and, you know, tracking what's going on from day to day, I think is particularly important right now.
Thank you. Sarah, maybe I can direct this one to you. Can you comment a little bit about how everybody on this call and anybody who cares about mental health can use perhaps social media to counter some of the stigma that we are seeing emerging, some of the xenophobia we're seeing emerging, particularly about Asians, which of course comes at all levels of government, and we've seen multiple reports of that in the community.
So how people can specifically use social media, that's a good question. So, and it's a funny one for me because I'm not a big social media user, but I do have thoughts about this. So I think the one thing we can do to combat stigma on social media is acknowledge that it exists and speak out against it. Because I think if you are from a stigmatized group, it can be very isolating and lonely. And hearing from people who are not in that group that they recognize stigma and that they think it's wrong can be really empowering. So I think, you know, calling out stigma and showing solidarity with stigmatized groups is really important.
Thank you. Kirsten, I'm going to smush 2 questions together. Any thoughts or recommendations about how during a time of physical distancing we can support 2 groups? Group A being immigrants or international students who are trapped in the US because of travel bans and as a result away from their natural support group. Group B, people who actually have mental health crises due to other factors and they are separated from a natural support group during time of physical distancing.
I think you give me all the really hard questions.
To spread them out, Kirsten. Spread out the hard questions. We're getting a lot of very good questions.
So I have a couple thoughts on students. I'm at Harvard, so I know we've been working with student services. We've been working with student services there, and I think that some of the things that we've been doing is reaching out. I mean, luckily with students and international students, they are on social media. They tend to be on social media and sort of avid consumers of it. So reaching out to students and helping them, either facilitating them preparing their own support groups, or and offering sort of some skills-based groups for them. So some of the things like Patricia's talking about, but for students specifically, so they can ask questions and they don't feel like there's like a bunch of, you know, faculty on who are going to criticize them. And then the other piece is helping them connect with their loved ones, et cetera, back home. So in some cases, what I actually heard today was something really interesting for we have some African students who are here and can't get back to Africa. and their loved ones can't get here. And there was some fundraising going on to buy to fund their homes in Africa to get like Wi-Fi and cell service so that they could connect. So there's some things like that going on that I would look at, and finding ways for students to be helpful, because I think altruism, doing something good for someone else, can be really helpful. And then people with other mental health crises, we've been doing some work with NAMI around that and trying to reach out to those populations, and also that folks are working with the Department of Mental Health to reach those populations. And one of the messages that I've heard from people who are doing that work is that in some ways those populations, because they're used to dealing with social isolation and had to struggle with issues of like not wanting to go to the pharmacy to fill scripts and things like that, they actually have a lot of the skills that some of us could learn from them in these situations. And so one of the things is, again, going back to what we're talking about other traumatized group, is to remind people that for people to be reminded of the skills they actually have, that this is a unique situation, but that pieces of it you've dealt with before, and you survived that, you have the skills to get through that. So you can use those again.
Thank you. Looking at the time, so I'm going to do just one question for each of the panelists. Number one, Patricia, I'll start with you. Can you talk about suggestions for working with youth in foster care? It's a question from an organization that works with youth in foster care, who obviously already have difficult connections. Besides trying to promote virtual interactions, other suggestions for reducing isolation and hopelessness in this group?
I'll say it from probably an abstract level, because I don't work with youth in foster care myself, so I'm not aware of all the potential barriers. But I would say that in a time like this, that there has to be a focus on safety, and there has to be a focus on finding ways to engage them, and it will have to focus on what they already are comfortable with. And so it's a very, very tricky situation. So if you have knowledge about specific ways that a child or a group of children already find comfort, or already find ways to connect, then I would amplify it. I mean, I would really try to amplify it as much as you can. It's particularly tricky with foster parents who, because they may be overburdened right now. And so a lot of what I've seen in the literature around interventions is not to introduce a whole bunch of new interventions. It's more about being more disciplined and reminding yourself more regularly, these are things that are particularly important right now. So if foster parents are getting overwhelmed and they're starting to take their attention away from children, they need to be gently reminded, or use themselves as reminders for each other. You know, we can't ignore. This is a particular time when we particularly can't ignore the needs of these kids. We have to, even if it's in smaller doses, 2 minutes or 5 minutes instead of 30 minutes, we have to remind ourselves to do it regularly. So all the things that we did before, we have to really be disciplined about now, even if it's much more small doses, but making sure you're doing it regularly.
Thank you, Patricia. Sarah, a question for you. I'm paraphrasing, but we keep talking about these things after an event happens, rather on a regular basis. Any suggestions for how we can weave these thoughts and ideas into how we interact with communities all the time to build resilience?
That's a good question as well. So, I mean, I think this pandemic is probably going to leave a different mark on societies than prior disasters, given its duration. So I can't imagine it being over and us sort of forgetting it, because of the impact it's had on so many people and so many communities throughout the world. So I guess that's one hopeful thing. And then I'm trying to think how we can keep these top of mind. I mean, I think having people continue to talk about them and know that these types of events are unfortunately, likely going to happen. We can make sure that we're taking them into account and making plans and budgets and things like that.
Thank you, Sarah. Kirsten, last question, something I know you've written about. I'm a high school teacher. My students have exposure to the media, but they don't have coping mechanisms. Classes have been canceled for a long time. They misstructure. When I lecture them, they cry. Top level tips. What can I do as a high school teacher best to help my students? And I would add to that as a coda, as a parent of high school kids, what are the best things that I can do to help my own high school kids?
Another easy question.
Yeah, another. Well, I'm the parent of an almost 13-year-old. So the things that, and I'm chastised for my terrible homeschooling qualities. So the things that I have done is try to set limits on the media that I listen to. So I find a written and radio less triggering than television. So I just don't turn the TV on media. Trying to set limits on and setting, my son has found it very helpful when his teachers have sent him work to do. He's actually been thankful for that, but that the expectations aren't as high as usual. So stuff that's review or that's very manageable, but that he sends in and the teachers can send back. The other thing that I would be careful about is any kind of group setting where people are sharing too much online. I think everyone's nodding. You have to be very careful with that. So I would have, if I was having a group, I would have something really structured. And then the other thing that it seems like kids are finding helpful is, can they make this into something where they're either going to learn something about it or help other people, like so turning into a learning thing. And then the last thing is there's a CNN channel I learned for adolescents, that it's like CNN 10 is for adolescents. And a lot of people have found that very, very good because it has a lot of positive stories.
Nice.
I want to say thank you to all our panelists. Really, what a terrific panel this was. Thank you for making the time. I know everybody is particularly busy at this point in time. And I want to say thank you to our audience. We actually had between this and Facebook, we had thousands of people joining, which I think reflects how much this topic resonates. So once again, thank you. And thank you to everybody for all you're doing during this time. Everybody stay safe and stay well.
Thank you so much for inviting us.
Thank you.